Thank you for joining us. Today's health briefing is the fifth in a series of briefings focused on presenting real-time discussion around the impacts of COVID-19 specific to vulnerable and at-risk populations in South Central Pennsylvania communities, inclusive of York, Lebanon, Lancaster, Hanover, and Gettysburg. This briefing is presented by Family First Health, a leading regional healthcare organization serving at-risk populations for the past 50 years. Family First Health is a federally qualified health center serving more than 20,000 patients annually. We invite the media and the public to submit questions in the comments section of this video post or in advance of our briefings by emailing healthbriefings@familyfirsthealth.org. Copies of the video briefing will be made available online at familyfirsthealth.org shortly after each briefing. We will begin momentarily.
Good morning. Welcome to another in a series of community health briefings offered by Family First Health. I'm Jenny Englerth, President and CEO of Family First Health, and today we're going to be taking a bit of a departure from our typical content focusing on data and numbers specifically related to COVID-19 and talking about a specific slice of impact related to mental health and substance use disorder that we've seen and experienced with our patients and communities during this pandemic. To get us started with a little baseline information, I'm going to share a slide that illustrates nationally what we have all been experiencing since mid-March. The Centers for Disease Control are sharing with us at this point, at least at a point in time during late June, 40% of US adults reported struggling with mental health or substance use. While we can't say that these numbers are directly related to COVID, we know that the activities of daily living, coping through this time, have created additional stress and strain for all of us. So we're going to be taking a deep dive in our time together today in how mental health and substance use have been impacting our patient population. I'm going to share a little bit more data before we dive into the conversation. At Family First Health, you'll learn more about our model of care. It includes and is really an important part of that model is screening for both depression and substance use disorder. If we look back into 2019, throughout that year, we screened over 40,000 of our patients for depression or substance use disorder. Those screenings created 1,200 opportunities for individuals to, in the moment of their office visit, be connected with a behavioral health service. And overall, we provided over 5,600 behavioral health visits to our patients within our primary care model. As I said, we'll dive deeper into our model in just a few moments. If we look specific to substance use during this time, and we even drill down into just one of the counties that we serve, we've seen a pretty incredible impact during this time. So even if we track through the early part of the pandemic, we see a significant uptick in fatal overdoses, again, as I said, in just one of the counties that we serve, York County, since the beginning of the pandemic. If we drill into our patient population specifically, we've also seen some trends that we are working to address differently as we move forward. In our specific patient population, through that same time period of mid-April, our patients had encountered 20 non-fatal overdoses. And most concerning to us is that during this time, 60 of the patients that we care for with identified substance use disorder have dropped out of care, or we are unaware of their status at this point, despite many efforts through a pretty comprehensive model of outreach and engagement to our patients. And we know that that puts them at higher risk to relapse and encounter a variety of other struggles during this time. So at this time, I'd like to introduce a colleague of mine at Family First Health who's going to join in our conversation today. Good morning, Dr. Kellett.
Good morning, Jenny.
Thanks for being part of our conversation today. Dr. Kellett serves in a couple of leadership roles for Family First Health. One is in our Columbia office, and today her leadership role in integrated services at Family First Health is what we're going to be focusing on. And when we say integrated health, Dr. Kellett, what does that mean to you and your role at Family First Health?
So the concept of integrative care is where in the primary care office, we also provide mental health services through behavioral health. We do screening of every patient over the age of 12 who comes into the office for both depression and substance use. And we also provide medical assisted treatment for those with addiction and substance use. So it's all in the context of primary care, and it allows us to work on the wellness and the wholeness. In addition to providing for their medical needs, we can provide for social and behavioral health needs too.
So I referenced just a moment ago a slide that talked about the screening that we do as part of that model. Could you elaborate on the importance of screening or the impact of screening that you've seen in your practice for mental health, depression specifically, and risk for substance use?
So in terms of what we actually screen, so we use a screening tool called the PHQ-9, which is 9 simple questions about how people are feeling emotionally. And it's been a validated tool, so we have good information about how people are feeling. And then we do substance use screening as well with that, every patient, every visit. What I think that's allowed us to do is, one, during the course of treatment for someone, especially with depression, we get to follow their numbers and see how they're doing. But also, we get to ask questions that sometimes we miss over and skip. And if they're there for a cold, maybe we're not thinking about their mental health. Or if they're there for a sprained ankle, I'm not caring as much, before about their alcohol use. There's one patient who I've cared for many years, probably close to 20 now, who followed me to this job. And only 3 years ago did I recognize that despite his type 1 diabetes, he's drinking a case of beer a night. And it was only because of this screening tool that I had any idea that I was like, how did I not know this? And he said, you never asked. So if we don't ask, we don't know the answers.
Right. I've had many folks raise a question to me about the incorporation of screening in our primary care setting and how useful that is. And based on stories like the one you just shared, I consistently am able to reiterate that one, sometimes if we ask the question, we get the answer. And if we ask the questions repetitively, we're more likely to get the full picture of what a patient is experiencing or bringing to the table. And it also helps to serve to normalize and reduce stigma. I think over time as another benefit. When I think about current circumstances, and we could cite many examples locally and across the country of situations where mental health or substance use disorder conditions are not managed, and they result in really tragic circumstances for all involved. We just referenced an increase in fatal overdoses and even non-fatal overdoses as one example of this in our community. One of the key elements to addressing these issues is access. Could you talk a little bit about access and how this model within a primary care setting supports access to these services in particular?
So I think the beauty of the way we are treating our patients has to do with the fact that we are a family doctor office. We are physician assistants and nurse practitioners and physicians just taking care of patients. And so that patient walking in the front door doesn't need to have a label put on them that says, I'm here for addiction help. I'm here for depression. I'm here because I'm having suicidal thoughts. That comes out all in our just regular visits. And so the stigma, I think, can be removed. I know that, with our substance use, we hook them in immediately to behavioral health. We give them recovery support, and we help them through medications that can help their addiction all in one place. And so, I had my patient the other day who was like, oh, you can do my pap smear too? Oh, you can treat my cold? Like, I can do those things all in the context of primary care.
Could you talk for just a moment about the connections that you continue to make? We focused on our model, we focused on the comprehensiveness of it within a primary care setting. But I would imagine that there are times when you as a provider and your patients need some extra supports. So how do you work in these areas? How do you work with other community providers? How does the team at Family First Health connect out into the community to make sure that the comprehensiveness of care that's needed for each individual extends even beyond our walls?
So in terms of mental health treatment, we offer behavioral health in the office, but there's times that people need more than when we can offer, and we can refer them for trauma-based therapy or other types of therapy. We have a psychiatrist that we can utilize here at Family First Health, but then sometimes we need to refer to psychiatry elsewhere. And same with substance abuse. There's times when our program is not the right program, and we will reach out and get them into a different type of program. The recovery support and trying to figure out how best that what support do people need? Is it online? Is it in person? Is it faith-based? Is it whatever it is? We can help hook them into those other programs to help serve their needs.
Thank you for making that point. I wanted to illustrate how important those connections beyond our walls can be for individuals, and that we are both looking at what we can do as an organization and the connections that we have with our patients, but also how we and our patients are connected in the broader community and with our partners there. Can you share any more examples that come to mind for you, how this model has impacted either your practice as a provider and how you approach your work, and or patient outcomes that you've seen as a result of being able to deploy this model?
So I'm a huge fan of this model. In the past, prior to being with Family First in this model, if something came up in the office, say somebody was suicidal, I'm sitting with the patient, I'm counseling with them, I'm calling 911, I'm doing all that. In this, we're a team, and I will get my my behavioral health person and have her come in and her sit and her help with that. And the same with addiction. It's amazing that on the days that I'm seeing patients with addiction, I have a case manager in the office, I'll have recovery support in the office, and I'll have another patient who's not part of the substance use program admit that they're using substances. And I have someone right there that can step in and help facilitate what needs to be done for the best interest in the patient. But what we do impacts people's lives. I have a gentleman who came to our program, and he was a medical mess, had many medical problems, many things that we needed to sort out, and he was also using heroin. And so by stabilizing his addiction and allowing him to work in recovery and do that, we could then impact all the medical things that were going on. And this guy 3 years later just had surgery and took no narcotics. And that is phenomenal.
Yeah, I think that the impact that happens every day in our offices is phenomenal, to use your terms. And when I think about the impact of this model, and the long-term effects. Everything in primary care, and I don't have to tell you this, but I always reinforce it, is kind of about a marathon. It's not a sprint. We want to develop long-term relationships with individuals. And so the idea of connecting about the breadth of issues that the individual is experiencing really helps guide that long-term intervention support of that individual, and hopefully helps us think upstream a little bit, right? So to really lean into that preventative side of your training as a primary care provider, and your desire to be able to intervene or intercept before conditions, whatever those conditions are, become overwhelmingly difficult to manage for the individual. And yet we're still there when people are in those situations as well.
Exactly. And you reference those numbers of those 60 patients who we don't know what happened to them, or the 20 that have had overdoses. And those patients, they come back. They say, I messed up. I've gotten to detox. I'm back here now. Whatever. And we're here to help them wherever they are on their journey, noting that addiction especially is a chronic relapsing problem, just like diabetes. And just like I won't say to a diabetic, I'm going to stop treating you because you're still eating cake. I'm not going to stop treating someone who is using heroin just because they're using heroin, but work them through to get to them and hopefully help them get to the point where they can be sober.
I think what you're describing is something that I've appreciated in my affiliation with community health centers throughout my career, which is that we strive to provide non-judgmental care. We meet people where they are, try to pick up as best we can with that individual, whatever life stage or circumstances they find themselves in, and then help walk with them to improved health, whatever that looks like for that individual. So currently, you're involved in a fellowship offered by University of California, Davis, that's focused on deepening your skills as a primary care provider in order to better meet the psychiatric needs of your patients, and then being able to pass along those learnings to your peers and colleagues, so that we as an organization overall increase our capacity to meet these needs of our patients. I know you're still in the process of that fellowship, but at this point, could you share a learning that has been, impressed you or impacted your practice to this point?
So the fellowship is called Primary Care Psychiatry Train New Trainers. So the interest I had was primarily what I thought was in getting more knowledge about the medications that we use for certain mental health disorders, for bipolar disorder, for depression, anxiety, just knowing the medications better. That's the psychiatry part. And the Train New Trainers is so I can help others and reach out to others and help them feel more comfortable with this, knowing that in the nation, we don't have enough psychiatrists. What has surprised me is that there is something called motivational interviewing, which I have really appreciated and learned, and they had us do kind of role play so we could learn the techniques better. But what motivational interviewing is trying to get a patient or a family member, even because I use it at home, to get from one place where they're not really thinking about changing a behavior to maybe starting to think about what they could change. So it's to motivate them. The work's not my work, it's their work. So for somebody like smoking cessation and then say, no, I don't want to quit. And then I ask, well, can I tell you a little bit why you might want to quit? And they say, sure. And so then we talk about it with an open, non-judgmental way where they can then realize that maybe it would be a good idea to think about quitting. And along the course of primary care and course of the visits, in 6 months, in a year, they may be ready to quit. Whereas if I just said, you need to quit now, it doesn't work. So I have really appreciated some of the additional training that I've gotten. And hopefully my patients are benefiting from that.
I really appreciate that you highlighted motivational interviewing and its impact within your practice and outside of your practice. And that kind of leads perfectly into something that I want to talk about. I know that you have a few kids at home with you during this this pandemic in particular. I have a teenage daughter at home. While we talked about how as adults around the country, almost 40% of us noted some kind of change or impact on our mental health during this time, it leads me to think about our kids immediately and the young people in our lives and in our communities and how they're navigating through this time. So how have you seen this play out in your practice with young people that you treat, maybe even in your own home? And what are maybe some words of advice that you might have for those of us who are thinking about and concerned about the kids around us that we could do to help bolster their resilience and their ability to navigate through these very uncertain and incredibly unusual times for all of us, even who are have longer lives, more experience, more coping skills, hopefully, and we're still struggling. So how do we best support our kids during this time?
Well, as you said, I have a few kids. I have 5 sons between 5 and 15, and they currently are all in school full time, which is not the norm. But so I've seen this in them. And I've seen, obviously, in the patients, and what I see most is that the kids are reflecting the parents' attitudes. So much of what our children know and do is because of what we know and do. So if the parents are feeling anxious and worried and fearful every time they go out of the house, the kids are feeling anxious and fearful and worried every time they go out of the house. In my kids, because we try not to live in fear, we put our mask on and we go and we stay separate. But my kids are all like, do you have your mask? Do you have your mask? Everyone's getting their mask and we're going. I personally found it a lot more challenging when they were home full time and trying to manage their schooling at home. Obviously that was a bigger challenge, but I think that's what happened. And what I see in the office too, is that everyone's anxiety is higher. People who were not anxious are maybe a little bit anxious. People who were anxious are really anxious, and not knowing what is going on in the world or even paying attention to news media 24 hours a day has made people kind of fearful and anxious in this time that is fearful and anxious. And just to validate those feelings and to talk to the kids about what are we afraid of or what are we worried about. Their answers are reflective of what their parents are saying, but their answers are, we're afraid of dying. Well, okay, let's talk about that. Let's talk about why you're scared of dying. Why, what are we really worried about? And so it gives that opportunity. But kids are struggling. We talked before, Jenny, that the numbers of child abuse are being underreported right now because the kids aren't in school, but the abuse is still happening. And so I think that the best way we can help our kids is to help the parents be able to parent better and with less anxiety.
And I'll ask you in a moment how how parents should be or could be interacting with their primary care providers to get the help that they need right now. But I also want to say that I think that, and this has kind of been my mantra pre-pandemic, and I'm trying to live into this even more right now, which is to really be observant and present when we are in public and encountering other folks. Entertaining a toddler in the grocery store line, even in a socially distanced way, and alleviating stress for a parent for a few moments in time is something that's helpful. Not sending a judgmental look to the family whose toddler is screaming on the floor. Those are small signals that we can all send as community members that we share a collective struggle right now. And that, just as you described, that even those of us who may have not experienced a lot of anxiety or depression in our lives are coming up against that. And those of us who may have had that struggle identified prior to COVID are finding even more difficult to manage. So just understanding that set point is different, and that we can all contribute, that those of us who may be in a strong place today may be able to lend a hand to somebody who is not today, and tomorrow we may need the same thing. So I want to loop back, though, to what you had to say about the impact of parents and adult caretakers in young people's lives and their ability to provide as consistent and stable and authentic presentation to the children in their lives to be the most help. So on one hand, that makes perfect sense to me, and on the other hand, that puts a little pressure on me as a parent.
Mm-hmm.
So if I'm looking for helps in that area, what might I expect, or could I engage my primary care provider in that might be of a help to me in this situation where I'm trying to do the best for my kids?
Well, I think recognizing that we're struggling, because I think a lot of us try and put on them, we're wearing real masks, but we put on a mask that everything is okay. And sometimes it's okay to say things aren't okay. Things are I'm really stressed out. I'm really worried, or I'm not sleeping at night. And I think in the primary care setting, that's a good place to talk about it. And there, it doesn't necessarily mean if you're talking to your doctor about it that they're going to say, well, go take this pill and you'll feel better. Sometimes it's saying, you know what, maybe you need to cut back on caffeine a little. Maybe we can get you better sleep. Maybe we need to talk about going for a walk and being outside. Maybe it's okay to say, I need to go take a break from my kids for 10 minutes and go hide in the bathroom. Whatever that is, I think it's in the primary care setting is a perfect place to talk about that stuff and talk about those feelings. And if you're there for your cold, or your sprained knee or whatever else, it's okay to talk about those other feelings, and to just know that you're going to have a provider hopefully that listens to those. And if it's too much, then we do that, what we call warm handoff, and we have our behavioral health person, usually an LCSW social worker, who can come and just sit with you and talk. And that is the best medicine.
Yeah, thank you for that. And that reassurance that a primary care office is a safe place to bring those conversations, and that they are appreciated, as we want to understand all of the circumstances that our patients are encountering and that are impacting their health. That helps us today and in the long term in interactions with that patient. As we get ready to close our conversation today, I'd invite anyone that has questions to put those in the chat. We've gotten a couple of positive comments about our just even raising the topic today and having this conversation. I think the more, as you just said, we can have these conversations with our primary care providers, the more that we can all talk about kind of where we are and how we're feeling, and do that in an authentic and genuine way. It's helpful. It's helpful to those around us in ways that we may not even recognize. So as we come to a close, Dr. Kellett, what are those things that, and maybe this is reiterating from earlier in our conversation or other thoughts that you have, but in thinking about our mental health and our risk for substance use disorder at this time, from your perspective as a family practice provider, what are those things that you would like us to take away from this conversation, or that are most important to you for all of us?
So I think that this is a really, you alluded to this, Jenny, we don't know what's happening. This is a very scary time for a lot of people. And it's caused a lot of division in people, a lot of judgment. And, it was easy when everyone was quarantined at home in some ways. And now that we're trying to venture out, this person's wearing a mask, this person's not. I think that the anxiety that we all feel, and sometimes depression, and that substance use, it stems from all of that. And what I'd like to say to people is be nice to one another and be kind. And yes, do I wear a mask in public? Absolutely. But I'm not going to get angry and be upset with someone else who doesn't choose to. I'm going to lead by example and do that. And I want people just to know that these struggles are real, that life is hard right now. And we don't know when it's going to back to the normal that we knew in January. And so we just need to be kind to one another. And I think our kindness and paying that forward will do more to help our society and help each one of us feel better internally than almost anything else.
Well, thank you. Thank you for that. Thank you for sharing your kindness with your team and our Columbia office, with our patients, and the community more broadly every day. I think the ripple effects that happen in our offices every day may not be known to us in the moment, but a lot of the work that we do is planting seeds, and particularly at this point in time, those seeds that we're planting are incredibly important. I want to remind anybody watching that or viewing this that we do have COVID-specific data for our patient population that will be the current data that will be made available on our website, as well as information related to our content and topic today. In the month of October, we will be having another community health briefing that will be focused on the importance of voting at this point in time, and the connections between the important policy issues in healthcare and our opportunity to cast a vote over in November. So please join us. Thank you again, Dr. Kellett, for sharing your expertise with us today. I appreciate you always.
Thank you, Jenny.
Thank you.
And we're done.
See, was that so bad?
No.